Thank you very much. This is going to be a very different talk from that. No bleeding, everything at all. I'm representing the Canadian Association of General Surgeons as well as the Canadian Association of Thoracic Surgeons. It'd be very difficult for me to discuss in the next 15 minutes everything about hiatus hernia. Therefore, I wanted to really highlight something that we do every year at our Canadian Surgical Forum. We have a symposium. Let's see if we can get this going. Can we get this started, please? Oh, well, I'm pressing the wrong thing. Okay, we have a, perfect, thank you very much. Every year at our Canadian Surgical Forum, at our annual meeting in September, we have one symposium where it's combined between the Canadian Association of General Surgeons and the Canadian Association of Thoracic Surgeons. We've done this for the past 3 years, where we try to give very practical talks on several topics of the benign esophageal conditions. This is from 2015 in Quebec City. You can see it's an evidence-based management of benign esophageal diseases, the two societies that support it. And we usually have either members in the thoracic surgeons or general surgeons talking on this. I'm a member of both. And we usually bring one visiting professor. Here you can see it's Adrian Park. In the following year, it was in Toronto. Here you can see again, here's Matt Hutter, who's talking about obese patients. These are all members of SAGES as well. And last year, again, in Victoria, and we have Dave Ratner talking about different topics. So the goal of this symposium, it's an excellent symposium, really covers a breadth of foregut disease. It's really to give very practical talks for the practicing general and thoracic surgeon on foregut. So I'm going to give you one of these talks, sort of to highlight our sessions, and hopefully they'll be able to join us next year, or this year, later on, where it's in St. John's, Newfoundland, which is an outstanding little town. This is a talk that I gave maybe last year or the year before on dysphagia that persists after heller myotomy. So, as you know, this is achalasia, a typical bird's beak with a dilated esophagus. Manometry, so endoscopy reveals a very dilated esophagus, usually with lots of food in there, and manometry reveals a typical achalasia pattern. Now, clearly the goal of this surgery, or any treatment that we do, is to palliate palliation of the dysphagia. We don't cure this disease, we just palliate this disease. So what are the treatments? Again, all the treatments are geared towards this. The treatments are, this is again apple pie mother talk, but clearly medications tend not to work very well, either long-acting nitrates or calcium channel blockers. The pneumatic dilatation has really overtaken Botox. So the Botox we still use in some patients who are quite poor performance status, and POEM are all options. However, clearly the standard of care, still the gold standard of this disease, is a heller myotomy, irrespective of what you hear out of the POEM talks. And heller myotomy is particularly effective. This is from, borrowed this slide from Marco Patti. As you can see, a bunch of series. This is sort of recapitulates what we see quite frequently in most series, large series, a dysphagia, relief of dysphagia between the 85% and 95% after laparoscopic heller myotomy. And these are durable effects. Now, this is a study that we presented here around a decade ago. One of my residents presented this work where we looked at 87 consecutive patients who had over 2-year follow-up and complete quality of life questionnaires. And you can see there is a very good control that's durable. However, there is some recurrent dysphagia in around 10% of patients that we see that occur if you follow these patients long enough. Now, we looked at this a bit more closely and looked at these patients, had 11 patients that had over 2-year follow-up, and found, and then we looked at those who complained of recurrent dysphagia, and we compared satisfaction scores in those patients, and then looked at, and all these patients were studied extensively, and we looked at those who were satisfied, had a satisfaction score of 0 to 1, meaning that they were satisfied with the disease, versus those who were not satisfied. Those who were satisfied, we were not able to find anything, and actually those required no treatment. The vast majority of them were resolved on their own, indicating that dysphagia is a very subjective parameter and may just be a disease progression, but those patients require nothing. However, those who were not satisfied, we found treatable causes in the majority of them. So let's go back. Again, what are the postoperative dysphagia? What is the etiology? We have to divide that into either persistent or recurrent. Persistence either could be incomplete myotomy, problems with fundoplication, could be the angle of the esophagus, a very tortuous esophagus, or it could be the wrong diagnosis. We've all been there, or those of us who do esophagus, all been there where we've been sent to patients for achalasia and it turns out to have either malignancy at the cardia. That's very important to reanalyze your endoscopy reports. And then recurrence, we have to look for bridging fibrosis. Is there a reflux-induced esophagitis and stricture that may be manifesting as dysphagia, disease progression, or malignancy? This is a patient actually, when I prepared the slide, it was a patient who was actually a success story. He was 25 years after a pneumatic dilatation and was lost to follow-up. He presented back to our clinic maybe 4 years ago with a squamous cell carcinoma of the distal mid-esophagus. And here you can see on endoscopy exactly what this patient looks like. We have to remember that patients with achalasia, if they have recurrent dysphagia, malignancy is a possibility, and I've seen it 4 times, 4 esophagectomies that I've had to do were from previous patients with squamous cell carcinoma, though it is very quite rare. And based on the group from Sweden, it's around 0.5% a year of progression to squamous cell carcinoma patients with achalasia. That is higher than Barrett's. So these patients, although the ASGE and AGA do not recommend surveillance for achalasia for malignancy, we tend to do it on a yearly basis in our patient population. This patient just got readmitted to my service 3 years after section esophagectomy for a complete pathically response squamous cell carcinoma with massive cervical lymph nodes. He's on the ward right now, actually. So when you have recurrent dysphagia, post-operative dysphagia, you have to restart the entire investigation, treat them as if they're a new diagnosis of achalasia. We tend to do that. It's usually acceptable to have initial bits of dysphagia. It's acceptable, but not always a standard. Most of these patients are quite happy. They get better immediately. However, we allow a period of time between 4 and 6 weeks before we start the periods of investigation. So again, just as if they're new patients, we start off again with barium esophagram, endoscopy, manometry, like we would with a de novo patient with achalasia. Start off with this contrast esophagram. This is what you want to see, a nice normal drain in the esophagus. The column of barium empties out into the stomach. You see a little bit of the fundoplication here. However, these are all examples of patients that we've had. This is a patient that actually I did. You can see my name right there. Who had an incomplete myotomy, a question incomplete myotomy, where that column of barium does not empty. In addition, another option is another possibility is another patient that we saw that was done quite a few years prior from a laparoscopic myotomy. You can see has a poorly created fundoplication and did not have a straightened esophagus. So that's why it's important. These information that you get from the barium esophagram, even in the postoperative period, allows you to direct your treatment. Excuse me. Endoscopy is what you want to see. There's a patient of mine who had a normal post-Heller endoscopy. You can see the esophagus. It can still be dilated. However, there's no pooling of saliva or food. And when you go down to the lower esophageal sphincter, you can just, a little bit of insufflation opens up that lower esophageal sphincter and allows you to pass quite easily. What you don't want to see is some of this. This is a patient with a post-operative after Heller myotomy. You can see still retained saliva. There's something going on with that. Another patient has a very tight lower esophageal sphincter. Compare this to this one here. We can just a little bit of insufflation that opens up that lower esophageal sphincter. Here you can see it's still quite tight. It's a patient with a lot of reflux esophagitis. So these patients may present with quote-unquote dysphagia, but actually only have really odynophagia, but they may feel that those symptoms are dysphagic, and that just needs treatment for PPIs. And finally, this is what you want to see is a patient who was operated on one of our sister institutions, and you can see he comes back 4 years later. He has a hiatal hernia. All the endoscopy gives you guidance of how you're going to treat these patients. So what about manometry? This is a normal post-Heller myotomy manometry. You can see a low lower esophageal sphincter, still no peristalsis, but a lower esophageal sphincter. That's what you want to see. You don't want to see this. This is one of my patients who still has a high residual mean of lower esophageal sphincter at 22. So what's the management of persistent or recurrent dysphagia? These are the options: pneumatic dilatation or some endoscopic approach, endoscopic poem, or reoperation. We'll sort of go into those options now. So first line, pretty much everyone, no matter what they show on the pre-op investigations, we will try pneumatic dilatation as a first line treatment, primarily for incomplete myotomy and bridging fibrosis. This is to address those issues. I tend to go relatively gentle. Now, particularly if they've had a posterior, if they've done elsewhere, they've had a posterior toupee rather than an anterior door. A little bit nervous about doing a pneumatic dilatation. The regular hydrostatic dilatation is absolutely useless, not even worth trying. But we would go straight to pneumatic dilatation if we find that there's an issue to deal with. And this is an example of a patient. I showed you the gentleman beforehand. A very tight lower esophageal sphincter, again, persistent disease, not draining very well. First thing we would do is try pneumatic dilatation. Now, start very, very small. You just start a 3 centimeter balloon. And this is sort of our standard cocktail for pneumatic dilatation, either de novo or for recurrence. Use a 12 psi, 20 seconds, twice. If you start off any higher than this, the risk of perforation shoots up. And if you do this, we find that if you do it anything more than 20 seconds, the risk of perforation is much, much higher. Again, this is the patient here who's undergone that pneumatic dilatation. Same gentleman you saw earlier. So what about reoperation? So again, if they fail pneumatic dilatation, we're unable to get an improvement in symptoms or objectively lower esophageal sphincter, these are the patients that may benefit from a POEM, but we tend to reoperate on those. Now, it's also very important for patients who have a large hiatal hernia. That's not going to respond to pneumatic dilatation or to a POEM. If there's issues with fundoplication, that's not going to respond to pneumatic dilatation or a POEM, and particularly of the tortuous or angled esophagus. We've had operating on a few of these prior to proceeding with esophagectomy, is to straighten that esophagus out. For example, this is a gentleman here. You can see a hiatal hernia. Distally, it does not respond. These tend not to respond. If the hiatal hernia is causing the dysphagia, it will not respond to pneumatic dilatation. Here you can see what we need to do here is reoperate on those, take down the fundoplication, and straighten out that esophagus and replace it on, redo the fundoplication. Now, where do we do the fundoplication? Again, we tend to do primarily a door at McGill, so around 350 Heller myotomies. I think 98% of them are doors. Toupees, very rare. I hate doing toupees for a number of reasons. One is that if you have to reoperate on them, that mucosa is plastered up against the liver and makes it really hard to deal with. So what we tend to do, some have described continue the same myotomy and continue it down, either distally or proximally. However, we tend to always recite our myotomies. If the initial myotomy was done at 11 o'clock, we'll go to the 1 o'clock. We'll go to the 1 o'clock position. If it was done at the 1 o'clock, we'll go to the 11 o'clock position. We'll just do a parallel 4 or 5 millimeters on either side of that, take down the myotomy, and redo a myotomy in a separate area completely. Also, we have to make sure the esophagus is straight. We had to reoperate on 2 patients with a persistent, rather than many people take this patient, just take out that esophagus. What we'll do, if we see a persistently tortuous esophagus like that, we'll take that patient back to the operating room and try to bring it down and make sure it's straight. So what you would do before you even actually do your myotomy, before you even do your fundoplication, you straighten out the esophagus, and attack the both sides of the esophagus to the crura. Then you do your myotomy, so you straighten that esophagus as much as possible. If that doesn't work, you have to operate on it. Well, you don't have to operate. You have to recognize that that esophagectomy is still a viable option for treatment of these patients. There's a patient we treated 55 years, had a previous myotomy open, failed endoscopic therapies, dilatation, pneumatic dilatation, redo Heller myotomy, still failed, and goes lap esophagectomy. These are interesting cases, actually, because this is one of the few times when your esophagus in the neck is like 5 times larger than the gastric conduit they're bringing up. So it's a friggin' huge anastomosis that you have to put those two together. But it is still relatively rare. The number of esophagectomies I've done for achalasia that do not have malignancy out of around over 300 patients with Heller myotomy are around 4. So it's around 1% of patients may require, at least in our institution, require an esophagectomy. This is sort of the algorithm that we take. So patient has achalasia, undergoes Heller myotomy. Do they have recurrent or persistent dysphagia? Next assessment is determine whether or not the patient's satisfied. Are you happy with the current situation? If they are, and they're not losing weight, and they just have recurrent dysphagia by their their own subjective parameters, then we may just leave that patient. If they're happy, we can only make them worse. If they're not satisfied, then we'll restudy completely. And that was with barium, endoscopy, and redo manometry, trying to give us a target of what the issue is. If the fundoplication issues, or there's tortuous esophagus, or the disease progression, and it just looks like it's no matter what we do, that even if you do pneumatic dilatation, it's not going to work, we'll do a reoperation with a halar myotomy. Redo halar myotomy, take it down, do it at a different site. If, however, the lower esophageal sphincter is the main issue and it's still hypertensive, as long as it's greater than 10 millimeters of mercury, we'll try it again. We'll try to get do a pneumatic dilatation again. We'll start really small balloons. Start the 3 centimeter balloon, and if that doesn't work, then we will try. This is maybe a role where POEM may be more and more exposed. Is to use the POEM in those redo operations because it can be quite difficult, particularly if they have an anterior previous toupee fundoplication, which makes the redo operations much more difficult. Thank you very much. Thank you.